Hey everyone, thanks so much for checking out my channel. In this video, I'm going to go over the rotator cuff. Now, there's a lot of confusion with the rotator cuff because a lot of times people are thinking, they have to have surgery. And in fact, as long as it's not a full thickness tear, in a lot of cases, you can kind of get away without surgery. Now, these are with partial thickness tears. And again, this depends also on how many of the tendons are involved and then also the other structures, in and around the shoulder joint. So let's discuss what is the rotator cuff. So the rotator cuff is made up of four muscles: subscapularis, supraspinatus, infraspinatus, and teres minor. So I'm going to show them to you. This is a right shoulder. Okay, so this is would be my right shoulder, and you'd be looking straight on at me. This is the clavicle, the collarbone. There's a humerus bone, the arm bone coming up here, the upper arm bone. This is a subscapularis on the front. You notice it's really big. It attaches over here on the ball. Let's flip this around. If you look at the back side, this is the infraspinatus, and it's, pretty big too. It's not as big as the subscapularis, but it is bigger. And then the teres minor, the smaller one that runs over here, that one also is going to kind of work with the infraspinatus. And so those two muscles kind of work as a counterforce to the subscapularis on the front side. Now, the one that a lot of people tear, probably the most common, he has a very poor blood supply, is the supraspinatus. That's that one that sits across the top right here. A lot of times people complain of pain across the top of the shoulder, comes across the top and then radiates down the arm. This pain can radiate down the arm. It can go down in the hand. That's not uncommon. It can radiate around the shoulder blade. All common areas to have this to radiate as far as pain. You may notice popping or clicking in the shoulder joint. And so, let's just kind of go over some options of what could be going on. Number one, what does the rotator cuff do? Now, the rotator cuff has several functions. One of those functions is, just like in the name, it helps to rotate. So that's external rotation, so hand behind the head. Internal rotation, putting the hand behind the back. Also assisting with raising the arm up and moving around, because it kind of works with this scapula as far as the movements on the ribs, and then its articulation and kind of coordination with the upper arm bone. Now, the other thing that it does is going to be increasing and decreasing acceleration. Like when you throw a ball, something like that, when that movement occurs, it does assist with acceleration, like speeding up, and then the deceleration, the slowing down of the arm. Now, one of the things that really is probably the most important thing that it does is decompression and stability of the humeral head. So when the rotator cuff becomes injured, irritated, torn, etc., the humeral head, so the upper arm bone, the bone from the elbow to the shoulder, will ride up and forwards a little bit into the socket. Now, a lot of people think about what's called impingement syndrome. Now they call that subacromial pain syndrome. And so what impingement syndrome is, basically, they used to call it impingement syndrome when I got out of school, but now it's changed some names or whatever. But so this is the acromion process here, okay? This is a coral cord process, and this is a subacromial arch right here. Now what happens is that humerus bone right here will ride up in the socket. So it goes up, and you see that space getting smaller, right? And then it goes forwards. So up and forwards a lot of times. So when you're raising your arm, especially overhead, that rotator cuff complex is not functioning like it should. And so that allows that to ride up in the joint. So I'm going to kind of show you on this model here that's just bones. Again, a right shoulder. I'm not really sure why, like every model I have, and I probably have 50 models, they're all for the right side. I don't think I have the first left side model, other than spine models, which are for both sides, but I don't have a left arm or a left leg or anything. Left hand, I don't know why. So again, same thing, same scapula, collarbone or clavicle here. So I'm going to turn, this would be like me facing this way, and you see how that ball, now it doesn't ride up this much, I'm exaggerating this, up and forwards. So you can see that up and forwards. And so when it does that, it's going to rub and irritate the tendons, right? So where are the tendons at? The tendons, that's these white structures that you see here. Those are the tendons, and tendons connect muscle to bone. So if I put this arm on its side, and you can kind of see how the ball sits in that joint. So think about like this is a saucer, okay? So this would be a saucer here, and the ball for the humeral head here is going to be a teacup, and the teacup must sit in the saucer. Now, when you raise your arm overhead and you move overhead, what happens is the humeral head is going to move some, right? We want to keep it centralized. We want to keep it right in the center of that socket as much as possible. And that's where the rotator cuff muscles come in. So the big shoulder muscle, the deltoid muscle, and the pec major, and the trap, and all these other muscles are going to move the arm upwards or raise it upwards or out to the side. And the rotator cuff is going to be kind of like the counterbalance that pulls back or down and keeps that centered in that socket. Okay, so when the rotator cuff becomes weak, that can cause some of that excessive movement, and that can cause irritation. The other thing that you need to mention is the bicep tendon. So our bicep, a lot of people think the bicep is just one muscle. So there's several muscles in the bicep or upper arm complex. There's something called a coracobrachialis. There's the biceps brachii or brachii. There's the brachialis and the brachioradialis. And so those are several muscles that function to flex the elbow, to flex the shoulder, so raise the arm up in the front or bend up and kind of make a bicep muscle. So the long head of the bicep tendon, okay, so or the long head tendon basically goes to the outside and crosses right across the front of the shoulder joint. So even though it's not a rotator cuff muscle, it functions like a rotator cuff muscle in a way, because it can, because of its crossing the shoulder joint, it can pull down on that humeral head and assist with some of that decompression. So a lot of times that's where we're going to talk about bicep strengthening being important, as long as the bicep tendon is still intact and it's not ruptured where it attaches within the joint. It has an inside joint attachment. Let me show you. So the bicep tendon, if you can see this groove right here, that's called the intertubercular groove. That's where the bicep tendon is going to run. And it runs up, runs into the joint, and attaches on the glenoid rim, or the teacup, the saucer rather. It attaches on the side of the saucer. All right. So a lot of times you can tear that, you can rupture that. You may notice, picking up on something one day and you feel or hear a pop in your shoulder, and you look up and your bicep muscle's kind of bunched up down by your elbow. You'll see some bruising. So that's a long head bicep tendon avulsion or tear. So anyway, okay, so now we kind of know what the rotator cuff muscles do. Now, what are the different kind of stages or classifications of damage to them? So the first is going to be just irritation. Okay, so the tendons are just irritated. They're inflamed. They used to call that tendonitis. Now, some folks still do. Now they call it a tendinopathy. So whatever you want to call it, the tendon is irritated and painful for whatever reason. And when that tendon becomes painful, not only does that refer pain around, but the other thing is its muscle that's attached to it can become tight, it can spasm, it becomes weak at times, doesn't function like it should. And so if we start with a slightly irritated tendon or tendons, because one of the four could be irritated, well, the next thing you know, we get a tight muscle, or we get a muscle that's not firing like it should. And so now we get this imbalance a little bit in the shoulder. And so then we can strain or stress the other muscles, the other structures, and they can become inflamed and irritated. It's kind of like if you start if there's a fire, or, in a dry area, a dry patch of grass, or, weeds or whatever, then all those structures next to it can catch on fire very easily. So it's kind of the same concept. And so once that becomes irritated and inflamed, now we got to treat it. And does that require surgery? No, especially not initially. So that can be cases where surgery is required if we start to develop what's called osteophytes, or spurs that come off of there. So these little bone spurs will stick off the bottom. This, again, is the acromion process, and they will kind of stick down on here and rub and irritate those tendons and kind of gnaw away or chew with the tendons, so to speak. And in those cases, you'll want to have those removed, because there's no way to exercise bony structures like that off. You can strengthen as much as you can and load the tendons, but a lot of times that's going to require surgical procedure. So I'll talk about that in a second. But with that rotator, when the tendons are inflamed, what do we do? So we know that strengthening or loading the tendons, right, that does very well. So you go through a progressive strengthening program. If it is, let's say, the rotator cuff muscle and its corresponding tendon that runs across the top here, that's that supraspinatus, right? So, of course, we're going to do supraspinatus exercises. Maybe I go a little lighter with those, more conservative. But the other three muscles, I'm going to really ramp up the strengthening on them to try to get them as strong as I can to help out that supraspinatus muscle. I'm also going to do bicep strengthening. Why? Because we know that bicep, that long head tendon, and the short head, both were going to cross the shoulder joint, and the short head's kind of coming across and over, but the long head is attaching straight or going straight over that shoulder joint. And then that's going to attach on that rim. So we want to make sure that we strengthen that, because the bicep, not only does that bicep brachii or brachii flex the elbow, so it brings the hand up. We know that it supinates, so if our palm is down, it helps to flip the palm up, and then it's also going to assist with shoulder flexion and movement of the shoulder, right? So we're going to strengthen the bicep as well. And a lot of times, if you can do that, and it takes a little bit sometimes, especially if it's that supraspinatus, the one across the top that's inflamed, because it has a very poor blood supply, it's avascular, and so it takes a while to heal. So if it's that one, don't expect 2 weeks and you're well. Just progressively exercise this and load it, and hopefully it gets better. Should you be pain-free while you exercise? Absolutely not. Very few people with tendon problems are pain-free when they go through their exercises. You're going to have pain. That's normal. I always tell my patients, as long as your pain, let's say that it's a 5, and then we exercise and we increase it to a 7, which in some cases when you exercise, you're going to decrease the pain as we kind of increase the blood flow to the tendon and kind of start moving. You have less of that kinesiophobia or fear of movement, afraid it's going to hurt, and it feels better. So either way, just at the end of the exercising or the training, I tell my patients within a couple of hours, as long as your pain goes back to where it was baseline before we started, then I'm okay with that. So if it started at a 5, we go up to a 7. A couple of hours later, it's back down to a 5. That's fine. If we started at a 5, it goes down to a 2 or 3, goes back up to a 5. Again, that's okay. Over time, that should get better, and your pain level should go down more, and the level that it goes to should go down. So that's just kind of over time. Now, in cases where this is just an inflamed tendon and you have those spurs we talked about earlier, right, those little bony parts that stick down, if you have to have those removed, that is called a subacromial decompression, right? So they go underneath. We're going to go underneath this bone, and they shave that out. They clean all that up and open up space. They may clean up any frayed tendons a little bit that's there. They're going to clean that up. And a lot of times they'll take the bursa sac out. So there's a fluid-filled cushion sac in here. That's called a bursectomy when they remove that. So they'll take that out, and you say, well, do you need that? No, not really. When they create more space in there, then there's going to be less likeliness that you're going to have that compression of the tendons up against the bone. So they just take that out. The recovery from that is very well. It goes easy. People have some achiness and kind of around the shoulder, some of that bone achiness where they shaved on the bone to remove the spurs and all. Usually people start exercising, right away within the next day or so. Go ahead and start exercising, range of motion, things like that. So that does really well. I've seen a lot of those over the years. And so that's when they don't have to really repair the tendon. Now, sometimes they go in there, they may have to put a stitch or a suture in there, and a little bit. Nothing maybe is so severe that they need anchors to anchor the tendon back down. So again, that's just your general inflamed rotator cuff tendons. Now, let's talk about tears. So with tears, we're going to go through 2 classifications. Okay, so the first is going to be a partial thickness tear. So partial thickness tear is the tendon is not completely into; it is still attached. So both ends are still attached, or it's still attached to the bone itself. And with that, you kind of have 2 options. You have the option for surgical intervention, okay, where they go in, clean any frayed tendons up. Maybe they need to remove some spurs, and maybe there's spurs in there as well. And then they put these anchors in. They anchor it into the bones. Kind of looks like drywall screws in a way. They drill in and anchor that screw into the bone. And then at the end, there's sutures, and they suture through the tendon and kind of fasten it all together. It works really nice. And so that's with a partial thickness tear if you need surgical intervention. After that, again, depending on how many tendons were involved and what other structures, if the labrum was torn, remember that labrum is that fibrocartilage that kind of holds the teacup. It basically, the labrum, if you're looking at the joint, the labrum is like an extender. It's almost like putting like a plunger, sticking the bottom of a plunger off of the shoulder blade, and then you stick the ball portion of the humeral head in, and it holds that. It creates a deeper socket for more stability, because the shoulder joint is very, very mobile, but it's very unstable. And in its ratio to mobility, it's unstable. So if they go in, depending on if the labrum is involved or if the bicep tendon's involved and all these other kind of things, then your recovery from that could range from give or take about 16 to 24 weeks. Now that depends if you're an athlete and you're going back to playing sports, or you have a job where you're like an industrial athlete, oil platform workers, iron workers, anybody that's very physical, delivery drivers, different things, then that time frame could be longer. And that doesn't mean you might not return to work, sooner, but there's still going to be restrictions of things that you can do, and you still are going to want to either go to therapy or do a pretty intensive home program with that. So that's partial thickness tears. And with partial thickness tears, let's say that you opt not to have surgery. And I have a lot of patients that do this. I've got one right now that we're seeing at my clinic that's not going to have surgery. And so we just build up the strength as much as we can and all the other remaining muscles, and then try to load the tendon, because we know that putting tendons under a load, a tensile load, helps the healing process with collagen fibers and all that. So we progressively load the tissue, and then we do massage and stem and all these other things, either, whether to feel good or to try to help things along. And, the patient can tolerate the exercises and movements and stretches more. So we do all those. And so you don't necessarily always have to have surgery. And you might not be able to have surgery because of health conditions, etc. So that's something just to discuss with your doctor with that. But there are options. It doesn't always require surgery. And some of that tendinous material will heal back, on its own, or putting under the load. You can, improve the collagen fiber formation of all that tissue that's still connected. So, and then lastly is going to be a full thickness tear. And that's where the tendon is completely torn into. And with that, a lot of times it's going to retract. It'll kind of roll up or kind of pull back. And then when it retracts, the surgeon has to go in and kind of find it and reattach it. So it's a little more to it. Typically with full thickness tears, unless it's a situation where you have health issues or you just can't tolerate the surgery, or you can't afford the surgery, whatever the situation is, typically you're going to have surgery on that. The people that don't, you have to go through pretty lengthy and strenuous strengthening program, range of motion. Some of those folks still have pain. So a lot of times we say, look, if you can, if everything's right and your surgeon's saying, hey, we should have surgery, I used to tell my patients, definitely go what your surgeon's, saying on that, and have it repaired. That way we can go ahead and start, making real progress to where there's going to be a real light at the end of the tunnel, so to speak. And with that, with full thickness tears, just like with the partial thickness tears, you're in a brace or a sling. So your arm is in a sling, if you can see my arm propped up here, but it's in a sling, and you've got this big pad that goes underneath it that's going to kind of keep your arm out to the side. You're going to sleep in a recliner. There's several different aspects of that. Getting dressed. I always tell patients, make sure, if you're going to have any of these surgeries, make sure that number one, you've got the recliner, prepped and ready to sit in, or chair, big comfy chair, whatever you got. You're going to want pillows to prop up your arm and all that. Of course, you're going to sleep in your sling initially. You're going to want shirts that button up. Button up type shirt, or a gown, or whatever you wear. You're going to want something that's really easy to get your arm in, that you don't have to really pull over your head. So you're definitely going to want to do that. You're going to have some pain. First few weeks are painful. It gets better over time. And the thing about it is, too, with the surgeons are so good with these surgeries now, you're going to feel better much faster than everything's actually healed. So I have patients at like 4 to 6 weeks are like, Chad, I feel pretty good. I can do these things. I'm like, no, we can't do them because the healing is not, is not fully, complete yet. So they're going to feel like you can really do more than you really can. So very similar to like ACL repairs. So you have to kind of take that slow, go by a protocol. I use protocols at my clinic. So you're going to want to use a protocol so that you don't, mess anything, up or anything. Kind of go slow with all of that, and definitely listen to your surgeon, listen to your therapist. As far as should you be doing certain things at home or not doing certain things at home, et cetera, et cetera. So you don't want to go in and have that redone. But with full thickness repairs, they do really well as well. And you're looking at, again, the same kind of thing. I would go a little higher and say probably somewhere between 18 to 28 weeks, maybe. Again, this can be less. I've had patients do much less. I've had patients do more. Everyone is different. Bone quality matters, especially if you're a female. If you have osteoporosis or osteopenia, then the bone quality, if they're using anchors, remember those kind of drywall type screws to screw into that bone. If the bone quality is not as good, you're going to have to wait a little bit. A lot of times before you go to therapy, they may make you wait, 3 weeks, 4 weeks, 5 weeks, 6 weeks before you start therapy. So you may be a little stiffer. The muscles have more time to become more weak. So several factors that kind of go into that. with a full thickness tear. But again, this all does really well. I mean, I've seen, I don't know how many in my career. I've been practicing almost 20 years or so. I've seen a lot, and the techniques have come a long way. And a lot of our therapy interventions and our progress and things that we used to say, don't do this. And now we're like, no, we need to be doing this because this is better for your mobility and your recovery. So all of that stuff is so much better. So you don't have to be too worried about all of that. And I have videos on my YouTube channel, my playlist, as far as like rotator cuff, what to expect, all those kind of things on there, and then some basic information on that. So you can check that out. But again, that is rotator cuffs from a little bit of irritated tendon to partial thickness tears to full thickness tears. So if you guys have any questions or comments, just please send them my way. And thank you so very much.